So today I will be presenting very briefly about the newer emerging data of immunotherapy in hepatocellular cancer. We all know immunotherapy is a promising and intriguing field. So, we will be briefly discussing about the overview of HCC and immune checkpoint inhibitors in the use of advanced hepatocellular cancer. So we all know that the most of HCC occurs in the setting of cirrhosis, and hepatocellular cancer is the fourth leading cause of cancer-related death worldwide. And in 2018, Globocan estimates for India, there we are expecting about 27,670 new patients per year, and approximately 25,627 patients died, which is a considerable amount of morbidity and mortality as we see the numbers. So there's a lot of scope where we can improve. We know it is a chronic process leading to chronic hepatitis to cirrhosis to hepatocellular cancer, where the etiologies may be varied. And if we look at the incidence and mortality, the same thing. The gap between the two is very minimal. So there is high amount of mortality as compared to the incidence. So we all know hepatocellular cancer is in true sense requires multidisciplinary care to improve the outcomes. Various people are the form: oncologists, radiologists, transplant surgeons, pathologists, surgeons. Everyone's role is important and different. So we all know it improves the outcomes. And if we look at the simplified recommendations, it is basically the systemic treatment is required for the people who are in the advanced stage or who are unsuitable for TACE or TARE or the local therapies. So with plethora of drugs available now, we have first line therapy and the second line therapies, which are standardly recommended. If we look at the systemic therapy use in hepatocellular cancer, so if we look at the like the evolution of the medicines in hepatocellular cancer, it was 2007 when the drug was first approved. It was sorafenib. We all know we were using sorafenib. What were the intricacies of using sorafenib, the problems of using sorafenib, but it was the only drug which was available to us. So in the frontline, sorafenib versus the placebo, definitely it improved the survival and it gave us an option to use. It was a sharp trial was the study which established this as a standard of care at that point of time, which improved the outcomes. So then came in 2017, it came the lenvatinib was approved. This was the study Reflect. It was a non-inferiority study which compared sorafenib versus the lenvatinib. We all know lenvatinib is better to use as far as the side effects are concerned. It is better manageable. But when we look at the OS differences, it was not statistically significant. So numerically, the PFS values and the time to tumor progression both were favoring lenvatinib. So we had one more option. So lenvatinib and sorafenib. Now, with the advent of immunotherapy in all the organ system, hepatocellular system has also seen its share of immunotherapy. So these are the different drugs, immune checkpoint inhibitors, which have been approved in different organ systems. In hepatocellular cancer, the immune checkpoint inhibitors are also recommended, and they are paving their way forward from second line to first line now. So it was after a hiatus of about 10 years that we have got to see the use of immunocheckpoint inhibitors in this setting in hepatocellular cancer. So in the first line setting, let's look at the data for the immune checkpoint inhibitors in the first line setting. It was Checkmate 459, which said Nivo versus sorafenib as first line therapy for advanced hepatocellular cancer. It was a randomized phase 3 study with a follow-up of 22.8 months. They're adults with advanced hepatocellular cancer who were ineligible or had progression disease after local therapy or local regional therapies were involved in this study. All the people in this study were child-pu A, as expected in all the clinical studies, and ECOG P was 0 to 1, which we don't get to see mostly in our routine to routine and real world scenario. And first line setting, so no prior treatment, people were randomized to into Nivo versus sorafenib arm, 1-to-1 randomization was there. and it was continued until progressive disease or unacceptable toxicity. The primary endpoint was OS. The predefined threshold for statistical significance HR of 0.84 was considered. And the secondary endpoints were PFS, overall response rate, association between PDL1 expression and efficacy. So when we look at OS and PFS, the median OS, if we look at the curves, they are merging and they are separating quite late. And nivolumab arm showed OS of 16.4 as compared to 14.7, and hazard ratio was 0.85 when the p-value was 0.07. So the predefined threshold for statistical significance for OS with nivolumab was not met, although it showed clinical benefit. We need to remember in the nivolumab arm, the overall response rate was almost double, 15% as compared to 7% in the sorafenib arm. If we look at the PFS was also almost similar. So both the primary endpoints were not met in this study, though it showed improved overall response rates. The other drug which has been approved in the first line setting is the atezolizumab in combination with the bevacizumab. It was again, I Am Brave was the study which established this as a first line therapy. It was a multi-center randomized open label phase 3 study. Previously, phase 1 study GO30140 had said established it had activity. Based on this study was conducted. Again, the patients were having locally advanced or metastatic and or unresectable hepatocellular cancer. Again, they had not received any previous systemic chemotherapy. Again, they were all Child-Pugh A and ECOG of 0 and 1. So they were randomized again, 2-to-1 randomization, atezobev versus sorafenib. Treatment was continued till PD or intolerable toxicity. Co-primary endpoints were OS and PFS. So we need to see this study included patients with high risk patients also, which were excluded in other studies like macrovascular invasion and people with patients who had more than 50% involvement of the liver or in which the main portal vein was invaded. So if we look at the OS and PFS and response, the curves have started to separate early. In the median overall survival at the time of follow-up, the atezobev, it was not evaluable as compared to sorafenib, which had 13.2 months of survival. Hazard ratio of 0.58, p-value quite significant. PFS again, atezobev 6.8 versus 4.3, hazard ratio of 0.59. So overall response rates, if we look at RECIST criteria, again, it was almost more than 2.5 times, 33.2 versus 13.3%, and with CR rates of 10.2% versus 1.9%. Again, the results shown by this study were very good. So based on this, it was established as first line, it was approved by FDA as first line therapy. So again, in ASCO, the patient-related outcomes were reported. If we look at the patient-related outcomes, the quality of life data, which is also very important, it favored atezo plus bevacizumab combination as compared to the sorafenib. So the other important question is we want benefit, but at what cost? Side effects. So were there any additional safety signals which were coming out of this study? So we all know it was very well manageable. The side effects were very well manageable. The only concern with use of bevacizumab in this setting usually comes from the varices. So in these studies, the 6 monthly evaluation was done, and upper GI bleeding rate in this study was not very different, 7% versus 4.5%, which is consistent with the historical data of use of bevacizumab in HCC in other studies. If we look at the side effects, mostly the people had hypertension, transaminitis, pyrexia, and proteinuria, which was more as compared to the sorafenib group. But definitely there was improvement in palmoplantar dysplasia and diarrhea, which was much better tolerated. So these side effects were fairly well tolerated and quite manageable. So the benefits were there and the side effects were quite manageable. So we have other checkpoint inhibitors therapies which are ongoing in advanced hepatocellular cancer, the results of which will be available in coming days. These are the combinations which are ongoing: LEAP, Himalaya, Cosmic, with different TKIs and the immune checkpoint backbone. And in the coming to the second line therapies, the people who have already been treated with sorafenib, we all know classically we have the second line TKIs which have been approved, like regorafenib based on the resource trial, cabozantinib based on the celestial trial, ramucirumab based on the reach 2 trial, and apatinib based on a help trial. So all these trials, drugs are approved. So the question arises, which we will come to it later. So if we use the checkpoint inhibitors in the first line, what are the options left to us in the second line setting? First, the data about this immune checkpoint inhibitors in the second line. So checkpoint 040, which was it had two phases: dose escalation phase and dose expansion phase. Here, the people with Child-Pugh B were enrolled, but only B7 were enrolled in the escalation and the expansion phases. All the people were ECOG BS1, and the previous who have received sorafenib were allowed. So coming to the expansion phase, there were 214 patients and 3 milligram per kg was used. The subsets were divided based on previously sorafenib intolerant or sorafenib progressor, SCV infected, HBV infected. Classically, we know sorafenib works well with the SCV infected people. So these are the results which were projected. So if we look at the untreated patients who were intolerant without hepatitis, the overall response rates were 23%. In the HCV infected people, the overall response were 20%. And in the hepatitis B, again, it was 14%. And the people who had progressed on sorafenib, but without hepatitis, they had shown the overall response rates of 21%. And so still after progression, this study had shown nivolumab had benefits. So if we look at the overall survival, so nearly 60% of the people who were on nivolumab, they were alive at 1 year, and the median OS was nearly 17 months. So it was same for all the groups. All the patients intend to treat 16.7 people per month was the median OS, and at 12 months, about 60% of the people were alive in all the groups. So extrapolating that, we can extrapolate that to the Asians, the overall survival by best overall response in the Asian cohort. If we look at the overall survival rates, so at the people who had CR, they maintained it at 24 months also, and the partial responses were there. Even the people who were able to maintain the partial responses, they were maintaining it at the 24 months also. And the people who had stable disease, they were maintaining it at the long term also. To say the people who had responses, they maintained it till long, and the people who had progressive disease, we all know they failed badly. So if we look at the overall survival by the etiology in the Asian cohorts, again, it was the people who were maintaining the responses, they were doing it all across, irrespective of the subgroups. So any correlation with the baseline alpha fetoprotein levels in the Asian versus in the Asian cohort. So in this study, as we can see, baseline AP levels were not associated with the response to nivolumab. And similarly, there was no association between the baseline alpha fetoprotein levels and the overall survival. So the other drug which was used in the second line setting was the Pembro. First study was 2 to 4, which was the phase 2 study. As it showed overall response rate of 17%, it was used in phase 3 study, which was Keynote 240 study. Here again, the Child-Pugh A, stage BC, ECOG PS of less than 1. Again, no high risk features. We need to remember the Atezolizumab had high risk features. So people were randomized again to Pembro versus placebo. Here again, the primary endpoints were OS and PFS, and the secondary endpoints were overall response rate, duration of response rates, and disease control rate, and time to tumor progression and safety. Again, though this study failed to reach the statistical significance for OS and PFS, this study showed median OS was 13.9 months in the pembro arm as compared to 10.6 months in the placebo arm. And PFS again was better, was almost similar in the both the arms. So though overall response rate was significantly higher with pembro as compared to the placebo, the median duration of response was 13.8 months with pembro. So there was subset of people who were responding. This is the third combination which has been approved from the Checkmate 040 study. It is the EP plus Nivo. The dose recommended is 1 milligram per kg of Nivo versus plus 3 milligram per kg of EP, followed by Nivo alone. So so we can see the arm A had 22.8 months of median overall survival as compared to median OS of 12.5 versus 12.7. So again, based on this study, this data, Nivo EP combination is approved in the second line therapy. So practical consideration, we look in when we sit in the clinic. So what are the challenges that we face? We all know not all the patients are child A. So there is data to suggest what is the evidence to say that child B patients will do good or whether we can use it there. So this study, the subset analysis from this study said that in this group of patients, again, the TRAs were manageable. Rates of discontinuation due to adverse events were not higher than child A cohort. And the hepatic treatment related adverse events were not higher in child B as compared to child A. And the overall response rates were 10.2%, not bad as compared to the standard child B patients, considering how they behave. So side effects are well manageable. We all know what are the side effects it can cause. And dose reduction, the only important point is the dose reduction of ICI is not a recommended strategy. And so coming to the end point of this talk, what are the important points for us to consider when using checkpoint inhibitors in hepatocellular cancer? With number of agents available, choosing a regimen requires a careful consideration. The important points to consider is previous therapy. Suppose the patient has received previously a transplant, so definitely we cannot use checkpoint inhibitors there. So that becomes an important factor to consider the previous therapy. Then the child status again is a very important factor in choosing our regime carefully. And comorbidities similarly play a good role. So again, the important thing is the rapidity of response required. We have seen though immune checkpoint inhibitors are good, but their response rates are very good. They are almost double to 2.5 times as compared to the conventional therapy. Not the rapidity of responses. Again, the important point is the financial, which we need to consider. So if immunotherapy is chosen as first line, the other question that remains is what are the options for second line and the sequencing. Traditionally, all the studies have been done with the sorafenib as the first line, and we do not know how to sequence and what is the data to support our second line agents. So the dotted line show the just the extrapolation, and the solid line is the actual data which we have. So in our real world scenario, the atezo plus bev definitely is a good combination to use in the first line, provided the patient is fit, does not have the contraindication, and finance is not a concern. Otherwise, Nivo in the second line option is a good option as of today, as far as immunotherapy is concerned in hepatocellular cancer. Apart from that, we have plethora of TKIs which we need to sequence, and in coming days, probably we'll see how to judiciously use ICIs in combination with the TKIs. With this, I stop here. Thank you very much. Again, I thank the organizers for giving me this opportunity. Thank you very much, sir.